have our speakers going to present, and then we're going to have time for a general Q&A. In-person attendees, please come to the microphones with your questions and comments so that the people attending remotely can hear the questions. And if you're attending virtually, please put your questions in the Q&A at any time, and we will incorporate as many of these questions as we can. And all of the sessions are being recorded and will be posted to the VCBH website and YouTube channel following our conference. Okay. And so it is my pleasure to introduce our speaker, Dr. Megan Roberts from Ohio State University. Dr. Roberts is an assistant professor in the Division of Health Behavior and Health Promotion at the Ohio State University College of Public Health. She did her bachelor's work at Cornell, got her PhD in psychology from Dartmouth, and did a postdoctoral fellowship at Brown University before joining the Ohio State University. And her research focuses on tobacco use among historically marginalized populations, particularly adolescents and young adults, racial and ethnic minorities, and individuals living in rural areas. And very impressively, her research methods include longitudinal surveys, ecological momentary assessments, or EMA, focus groups, and community mapping. And so please welcome Dr. Roberts.
Thank you, and thank you for joining me during your lunch break. So this presentation will be a bit different from the general theme this year's conference, but I hope you'll still find it relevant and interesting. And before I get started, I want to also acknowledge the wonderful collaborators who have worked with me on the projects I'll be talking about, as well as some of the funding that supported this work. So this is an overview of what I'll be covering. First, I'll provide a brief synopsis of what rural tobacco use is, with specific focus on challenges and kind of where we are now. I'll then get into why tobacco retailer density is a concern, including for rural populations, discussing it from an overall population health perspective, as well as in terms of rural health disparities. And then finally, I'll discuss a policy approach that's been successfully used to combat tobacco retailer density, which are licensing law strategies. So to get into the first topic, one of the biggest challenges is with rural research is just defining what is rural. So there's not really a straightforward answer to this question. There are actually several widely used definitions of rural. These are three of the major ones that are out there. The US Census Bureau defines urbanized areas and urbanized clusters, and everything else is rural. The OMB has metropolitan, micropolitan, and non-core or rural areas, which can be further divided into RUCCs, which then also gets confused with RUCAs, which is the third definition up there, the USDA's definition, which has metropolitan, micropolitan, small town, and rural areas, which can also be broken up into smaller areas. So all of these use different criteria, different methods for defining urban and rural, and this can be challenging for researchers because depending on the definition you use, you might come up with different conclusions. I should note here, I know your rural center often defines based on HRSAs, which actually uses a combination of all three of these definitions when they're classifying a county as rural or not. I also worked with a group that tried to develop an additional definition, partly in recognition that a lot of these measures were originally developed to define urban areas and focus on urban issues, and then kind of by default, everything not urban was rural. So this group that I worked with developed a continuous isolation measure, and values were determined by distance to an urbanized center and selection of a detailed parameter. After this measure, this isolation measure was developed, we then validated it on some really cool outcomes like nighttime lights, as you can see here, as well as land cover, access to different sources such as hospitals and internet service, And this investigation demonstrated that the isolation scale was a pretty good measure of rural. Finally, we examined how well these various measures explained variation in tobacco outcomes in terms of model fit. So we used data from the current population survey tobacco use supplement, and we were looking at model fit. What we found was that the OMB measure actually ranked the best in being able to classify urban and rural tobacco use, followed by one of the iterations of the isolation score. I should note too that we found similar outcomes when we were looking at other kind of secondary outcomes like attitudes for different tobacco policies, provider recommendations for cessation, things like that. So this suggests that the OMB and the isolation measures might be the most sensitive to detecting many types of urban-rural differences. So we would recommend using one of those two measures when conducting rural tobacco use research. However, we know that sometimes that's just not an option, especially when you're doing secondary data analysis. You just have to use what measure is out there. So this is an ongoing concern. We just have to be aware of how it can confound the literature. A next major challenge with rural tobacco research is that there's wide heterogeneity of rural. The United States is huge. So even when we're talking about urban-rural differences in the United States, that's covering a lot of the population. This is a figure from a paper by Holt that nicely maps out some of the major pockets of rural, including the Appalachian region, Mississippi Delta, different rural tribal lands. The point here is that there is not just one rural culture. Saying so would be a really oversimplifying the matter. All these areas have their own unique cultures, often their own racial ethnic composition, and the research bears this out too. So showing that even in the case of tobacco, not all rural areas have the same attitudes or beliefs or behaviors. Even where in Ohio, where I do a lot of my rural tobacco research, we have an Appalachian region. So this map is actually showing you land cover, and the green is kind of the more forested area. So that southwestern part of Ohio is that rural Appalachian region that kind of cuts through the state. But then in the northeast part of the state, it's kind of more flat farmland, which is also rural. Two very different rural cultures, different accents. And even with those, there are different subgroups like our Amish population. So the challenge is just to be careful about not overgeneralizing findings. We might look at differences at a national level, and I'm actually going to be doing some national urban-rural comparisons, but we also need to be mindful of these differences, particularly when we're designing interventions or thinking about culturally specific risk and protective factors. So getting into then where we are now, what's the current state of rural urban disparities? I'm going to talk just briefly about those, including unequal declines in rural tobacco use and some new products that might be on the horizon. So to start with main effects, we can do so with a paper conducted a number of years ago, including some of the folks here in this room, Steve and Diana. I believe you were both authors on this paper with Nate Dugan. But this does a nice visual demonstration of urban-rural differences. So the legend up there is showing you the ratio of rural to urban use of different tobacco products. A white or lighter color is showing you greater urban use. Gray, similar to the background color, is showing you kind of no difference at all between urban and rural. And then a darker color would be greater rural than urban use. So just to orient you there, first we have menthol cigarettes, which tends to be more of a urban behavior. So you can see it's a much lighter map. But then if we get into an outcome like daily cigarette use, the map is getting darker. Most regions of the country, we're seeing greater rural use compared to urban use. And then if we get into an outcome like smokeless tobacco use or chew, even more pronounced, much more common behavior in rural parts of the country. And then not only are we seeing main effects, but we're also seeing differences in trends. So although cigarette use continues to decline across the country overall, the rate is occurring more quickly for urban and suburban areas. So you can see from this gap, for the past 10 years or so, we were seeing a widening disparity between urban and rural tobacco use. And then finally, I just want to briefly mention some new products that might be on the horizon for rural tobacco use, specifically oral nicotine pouches. These were introduced to the US in 2016, and the number of brands and flavors has really been exploding. These products include nicotine, but make advertising claims about being tobacco-free, which is very confusing for the lay population. And so in ongoing work led by some of my colleagues at OSU, including Darren Mays and Brittany Keller-Hamilton, we're examining their appeal to Appalachian smokeless tobacco users. There's ongoing questions about whether these could be harm reduction products. So could we get people to switch completely from smokeless tobacco to a less harmful oral nicotine pouch? Are they going to be the next snooze, meaning that they kind of don't get taken up too popularly? Or troublingly, could they be substitution products where cigarette users or smokeless tobacco users are using these products when it's just less convenient to be using their preferred product of cigarettes or smokeless tobacco? So these are ongoing questions that we're investigating. Okay, so that was kind of your very brief exposure to baseline kind of rural tobacco use differences. What I'm now going to get into is tobacco retailer density with a specific focus on rural parts of the state and the country. And I'm beginning here with a figure of the socio-ecological model. I'm sure a lot of you here are familiar with this model, but I'm using it as kind of a framework. Basically, this model organizes factors that impact behavior into different levels. So if we're talking about tobacco use, at the intrapersonal level, we might have peer and family use impacting a person's likelihood of smoking. Institutional level, we might have enforcement agencies or state and local health departments. And then at the community and policy level, we have factors like exposure to point of sale marketing or the density of tobacco retailers where you live. And so when we talk about addressing tobacco use, the individual level, this could mean cessation counseling. Institutional level, this could be state quit lines or school prevention programs. And then at the community policy level, this could be more kind of broader factors like tobacco 21 or taxes or retail licensing. So for the rest of my talk today, I'm going to be focusing on that broadest level, that community and policy level factors. And also just to clarify what I mean by tobacco retailer density, by that I mean how many retailers are selling tobacco in an area. These are all kind of more Ohio specific stores. You might not recognize all the names. But retailer density can be looked at in terms of area, so number of retailers per square mile, for example, or at the population level. So for example, number of retailers per capita. And then why is tobacco retailer density a concern? Well, there's a strong body of research indicating that greater density of tobacco retailers, so if you live or work or go to school in an area with greater density of retailers, you are then going to have more access to tobacco, right? So it's just easier for you to get your hands on it, especially for younger people. And you're also being exposed to more tobacco marketing, right? Because there's more power walls inside those stores. We're seeing advertising outside from gas pumps to store windows all over the place. So you're just exposed more to tobacco marketing. And then again, a really strong body of literature establishing that more exposure and more access to tobacco distorts adolescent perceptions about the availability and popularity of tobacco, increases adolescent curiosity about tobacco use, increases likelihood of smoking initiation among young people, and also has been found to impede smoking cessation among people who are trying to quit. Okay, so main takeaway, retailer tobacco density is a big concern. At OSU, we recently completed an adolescent cohort called the Buckeye Teen Health Study, which sampled from both Columbus, an urban area, and several Appalachian counties that supports these findings. For example, we found that even among non-users, youth who reported more exposure to tobacco marketing had more positive attitudes about those tobacco ads. And we also found that in our EMA study, when we asked about where they were seeing tobacco advertising, the most common places where advertising was reported was not necessarily online or on social media, but it was at those retail points of sale. So at convenience stores or gas stations, that was the most common location, followed by grocery stores or supermarkets or pharmacies. And then tobacco retailer density is not just a population level concern, but it's also an equity concern. Because there's been strong data indicating that density disparities are greater in areas with higher prevalence of poverty, higher prevalence of African American and Hispanic individuals, and a higher prevalence of LGBT individuals. And we've really looked at this in Ohio. So here is a map where we've plotted the location of the over 11,000 tobacco retailers in this state. And we use spatial statistical methods to examine their per capita density. So here, darker colors are indicating census tracts with greater per capita density of tobacco retailers. So what should stand out to you first is we have this urban effect. So here is Columbus, where Ohio State is located. This is where I live. And here are some other major metro centers: Cincinnati, Cleveland, Toledo, Dayton. So you can see darker density. Again, this is counting for population size. Greater density in these urban areas. Then you can see there's this kind of lighter color outside them, and this is the suburb effect. So even accounting for population size, less tobacco retailer density in these more advantaged areas. And then finally, we have a rural effect. So again, if you remember from my previous map where the Appalachian region is. So again, counting for population size, we see greater density in the rural parts of the state. And again, this is something we demonstrated statistically. Oh, I'm so sorry. I'm fighting a cold. Those of you who have children know kids bring home lots of stuff. All right, so in terms of urban density, I also want to point out that much of this is also interacting with poverty. So this map is showing you poverty rates in Franklin County, where Columbus is located. Darker colors are indicating higher poverty rates in the census tracts. And then when you overlay this with, oh, thank you. If you overlay this with density of retailers, you can see how much of a relation there is. And this, again, we demonstrated statistically. Sorry. I'm also going to spend a few minutes describing some of the disparities we found by retailer type, specifically looking at convenience stores and discount or dollar stores. So using the same data, we coded our census tracts into different categories. So we were looking at race, ethnicity, poverty, and urban, rural, suburban status. To improve statistical power, we combined census tracts that were high for the state's two largest racial ethnic groups, which was African American and Hispanic. So that's what high and low minority means. And we use this categorical approach rather than examining main effects because we really thought there were qualitative differences between these groups. So, for example, high poverty urban tract is going to be qualitatively different from a high poverty rural tract. Okay, so first, for all types of census tracts, convenience stores were the most common type of place selling retailers. So over 50% of all types of tobacco retailers in every type of neighborhood were convenience stores. However, there were still differences. Specifically, convenience stores were most common in high poverty urban areas, regardless of minority status. Kind of the opposite effect for grocery stores and pharmacies. So grocery stores were most common in kind of the low poverty urban areas, as were pharmacies. So higher prevalence in kind of the more high income, more affluent parts of the state. Okay, for discount stores, we found there were significantly more in rural areas, as well as in high minority urban tracts and high poverty suburbs, as well as in low minority, high poverty suburbs. And then tobacco shops were more common in low minority, high poverty urban and suburban tracts. And then finally, there are also some more pronounced differences based on urban, rural, suburban status. So we found vape shops and hookah retailers had their highest prevalence in the suburbs, kind of those more affluent areas. And then bars and restaurants selling tobacco products were more prevalent in urban areas, and alcohol stores were least common in rural areas. So to kind of summarize all these findings, going back to my statement that tobacco retailer density is an equity concern. For rural areas, we saw greater per capita density compared to the suburbs, and disproportionately high prevalence of discount stores. And there also was a recent paper indicating that of all the types of stores that sell tobacco, these discount stores are the most increasing. So the prevalence of discount stores is increasing compared to all these other types of stores. So this is especially concerning, seeing that they're so prevalent in rural parts of our state. Further, these are often compounded by other place-based disparities. So, for example, rural areas often have lower prices for the cheapest brands of cigarettes, and they often have, or they're more likely to violate age of sale laws, meaning they're more likely to sell to underage purchasers. So, given all these concerns, how can we combat tobacco retailer density? And how can we do so equitably? And this brings me to the last section of my talk, which is about licensing laws and how they could help. So a licensing law is a policy that requires stores to obtain a license to sell tobacco. Not all states in the country have this type of licensing law. I looked it up. Vermont does have a statewide comprehensive licensing law. So if you want to sell tobacco, you have to pay a $110 annual fee, which is pretty comparable to other parts of the country. Although I'll get into this, but it does not have a designated fund for enforcement. So it does these funds paying for the license don't necessarily have to go into enforcing tobacco sales. But there are many advantages to general licensing laws like this. First, they provide an inventory to track and monitor retailers, right? So it's very hard to know who's selling tobacco if you don't have some sort of inventory like this. So this can really help the enforcement body, whether it's the police or the public health departments who are making sure that places selling tobacco are carding like they're supposed to and selling only the products the way they're supposed to be sold. It also poses a barrier to selling tobacco. So if you're having to pay an annual fee, maybe a pizza shop that's selling a couple other convenience items is going to decide it's not worth it. And so that's just going to automatically cut down on density. And then finally, if the law is written in a useful way, it will provide funds for enforcement. So the funds from those licensing fees get directly funneled into the enforcement bodies, pays for those people who are doing inspections. But licensing laws can also do more. They can set additional stipulations aimed at restricting or reducing the density of tobacco retailers in an area. And when this happens, they're often referred to as licensing law strategies. So these are the 4 most common types of licensing law strategies that exist in the US. To walk you through them, first we have capping, which is when you cap the number of retailers in an area. This is generally based on population size. So you might say there can only be 1 retailer per every 1,000 people who live in this county. Declustering is where you prohibit retailers from being in close proximity to one another. So you might say you can't open a new retailer if it's within 500 feet of an existing tobacco retailer. School-based is where you prohibit retailers from being close to schools, right? This is in line with a lot of other, zoning laws like selling alcohol or selling firearms. So, you can't sell tobacco within 1,000 feet of a school premise. And then pharmacy-based is where you prohibit the sale of tobacco in pharmacies. I'm noting here that all of these have been successfully implemented in the US and are considered legally sound, meaning that they've withstood tobacco industry attempts to take them down. Okay. I just have 3 cities here featured with their current licensing law strategies. And I'm also noting how they're often implemented in combination. So if you're going to go through the work of implementing a licensing law strategy, often you kind of put up more than just one at a time. So simulations and preliminary evaluations of real world situations indicate the powerful potential of these strategies for reducing retailer density. However, at the start of our project, we found that little work had examined how they would impact density disparities. So we knew that there were these existing disparities in Ohio and elsewhere, but we wanted to know, what would these licensing law strategies do to these disparities? Would their impact be equitable, or, and this would be a big concern, could they unintentionally exacerbate disparities? So to investigate this, I worked with a spatial statistician, and we simulated the 4 main types of licensing law strategies. We also tested out some different strategy combinations. As I noted, this is often what happens in the real world. And then using spatial statistical methods, we evaluated how each strategy would impact density disparities. So I apologize for the small font. These are some of our outcomes. Just to walk you through some of these. So this is showing you % reductions in retailer density from baseline. So for example, over with that circle is for a school-based 1,000-foot strategy. And that column there is showing you African-American census tracts. Low prevalence African-American tracts, there was about a 9% decline in density. High prevalence African-American tracts, nearly 18% reduction in density. So this is what we would call an equitable outcome. All types of tracts are seeing a reduction in density, but it's happening the most in the areas that need it the most, in this case, high prevalence African-American areas. For a pharmacy-based ban, it actually had the opposite effect. So you can see it was a 7.6% reduction for low prevalence African-American, only a 5.7% reduction for high prevalence African-American. If you remember from my rainbow bar graphs from before, there's just a higher prevalence of pharmacies in the more advantaged suburbs. So this makes sense. A pharmacy ban is going to help the areas that have more pharmacies. Going over to urban rural areas, we found that capping was actually one of the most effective strategies for rural areas. So you can see not a major change for urban or suburban parts of the state, but nearly a 13% reduction for rural parts of the state. Kind of an opposite pattern for school-based though. Not much of a difference between suburban and rural areas for school-based, although higher for urban. And then interestingly, these combinations kind of met both standards. So we saw, compared to the suburbs, greater reduction in urban and in rural areas in terms of density. So to pull this together in a summary, we found that the most impactful licensing laws really depended on the type of community. For example, school-based reductions were equitable for low-income African-American and urban neighborhoods. And then capping-based reductions were equitable for low-income as well as rural neighborhoods. And this makes sense if you think about the distribution of retailers as well, right? So in an urban area, things are just more clustered together. So you're going to have retailers closer to stores. In a rural area, places are often a little more widely dispersed. So something that's based on distance, like reducing retailers within 500 feet of each other or reducing retailers within 500 feet of a school, it's just not going to capture as many retailers as something as capping. We also found that across the board, pharmacy-based reductions demonstrated inequitable impacts. So regardless of any of these types of disparate groups we were looking at, pharmacy-based reductions were really helping the most advantaged suburbs. I also really just want to emphasize that when matched with the appropriate licensing law strategies, we found that communities could reduce the prevalence of tobacco retailers by over 20%. So this table summarizes what I discussed in the text. It shows you which licensing law strategies work best for which communities. This is actually from a fact sheet that we've been distributing to different places in Ohio. I work with a couple different coalitions in the state, and we've been slowly bringing licensing laws in general, and also Hamilton and is one of the first cities in the state that brought a licensing law strategies to its area. So we're excited to have our state catching up with the rest of the country and starting to bring some of these licensing law strategies in. So bottom line is that if selected appropriately, licensing law strategies can have a large and equitable impact on reducing retailer density. Couple additional notes. We found that combination strategies were more impactful in their equity effects than any single type of licensing law strategy on its own. And then not surprisingly, but stronger versions of policies were more impactful in their equity effect. So we looked at 1,000-foot and 500-foot rules. Some parts of the country have only a 200-foot rule, but we would definitely encourage wider distances for not only a greater impact, but a greater equity impact. For those who are maybe considering bringing some of these types of strategies to your neck of the woods, Change Lab Solutions and countertobacco.org provide really nice basic information, more information on zoning and retailer density. And then there's also 2 organizations I'd recommend that actually help local communities with policy drafting and advocacy. These are Preventing Tobacco Addiction Foundation, sometimes called tobacco21.org, as well as the Public Health Law Center. And it's tobacco21.org that was really impactful in bringing the first licensing law strategy to Ohio. Couple other policy considerations that are important to note, and I often get questions about. First, most policies implementing licensing law strategies only impact the purchase of future licenses. So they don't shut down existing retailers or revoke licensees. Rather, they occur for situations like a new retailer opening or maybe a new purchase. So, a current owner leaving and selling their store location to a new person. That would be a case where a licensing law strategy would come into play. Third option would be if during an inspection, a retailer is found to have broken whatever that state's licensing laws were in terms of selling to minors. Often there's a warning and then a penalty, but that final penalty can be revoking your retailer license. So all this to say, the impact of a licensing law strategy is kind of a slow burn. It doesn't happen automatically. It could take many years for it to kind of come to its full effect. The benefit is that this means less resistance from retailers. So when you're trying to pass a retail license, or retail license strategy, retailers are often in favor of this because to them, it means that there's an elimination on competition, right? New competing places can't open down the block from them. So it's often a little easier to pass at the local level. Second, as pharmacy-based reductions demonstrate unequal impacts, we recommend that communities implementing pharmacy-based reductions should do so in combination with other equity-enhancing strategies. So I would not say that pharmacies should be selling tobacco. A place that should be promoting health, like a pharmacy, probably should not be selling tobacco anyway. But if you are going to try to ban pharmacies from selling tobacco, definitely consider doing it in combination with something that also fits your community in an equitable fashion. And then finally, I'd like to point out too that licensing laws support Tobacco 21. This is something that often comes up when a state is now trying to enforce Tobacco 21 in their area, making sure that people are not selling to underage. Again, because of the infrastructure and the funding and the enforcement, that these types of policies can really work well with other existing local level policies. So that brings me to the end of my presentation, and I'm happy to take questions. Should we switch?
Yeah.
Okay.
All right, thank you. Megan, thank you very much for an excellent presentation. I want to invite anyone with questions to come up to the microphones. Maybe while people are gathering their thoughts, I can ask you to maybe describe some of the challenges of implementing these licensing laws. You said they've withstood legal challenges, but does that mean tobacco companies don't try, or what are some of those challenges?
Yeah, I think is this working?
I don't know. Is this pull closer?
Yeah, so the tobacco industry did not come to Hamilton, Ohio, but they have when they were first introduced in areas like San Francisco, New York, I think there were some kind of more industry challenges to them. But so far they have withstood, First Amendment arguments and things like that, because it's not a matter of free speech, as people originally tried to ban marketing at tobacco retailers. That did not withstand challenges. Yeah, so far these have been able to pass and withstand challenges.
Okay, great. I see we have a question.
Yeah, your concept of equity in pharmacy. The issue of pharmacy is pharmacy deserts. Rural communities and inner city communities have fewer pharmacies. It's a paradox, actually, you're describing, because the richer you are, the more access to pharmacies you have, which means more access to those pharmacies that choose to sell tobacco. It's less of an equity argument, more a paradoxical argument that rich people are at greater risk for tobacco sales than poor people, not because there's no interest in selling tobacco in poor communities, but because there's no interest in having pharmacies in poor communities.
Yeah, that's a great point. And I think it depends. I don't want to say depends. It's definitely the types of retailers that seek out different types of communities. So, right. So it's about profit for sure. And so where dollar stores are choosing to open in rural areas and in poor minority neighborhoods in Ohio, I think dollar stores are definitely predatory, and a lot of these convenience stores are very predatory. So yes, where they are choosing to sell, just like you're seeing grocery store deserts and pharmacy deserts in less advantaged areas, and these dollar stores, discount stores in places that have been historically disadvantaged, for sure. I agree.
Yes, Diane.
I'll ask a question. So where does your data come from with looking at the these retailer licensing laws and the effects on density come from? So is it all associative, or are they actually, can you look at the impact of a law going into place and eventually, I know you said it was like a years long process to see some of those effects, but is there actually some data on what happens when you change these regulations?
Yes. So it's been, because they've only been passed in the past 10 years or so, there are less examples of them actually being evaluated. But I know Philadelphia has done some evaluations, and New York City has also done some evaluations. Actually, New York City had passed some pharmacy bans, and they found inequitable impacts from their pharmacy bans. But Philadelphia had some more kind of what we would call equitable bans. And so they were seeing kind of a positive impact of their density laws. As far as I know, those are the only two cities that have done peer-reviewed published evaluations. San Francisco also has some kind of like fact sheets and outcomes from their work as well. Yes, a lot of it so far is just kind of hypothetical simulations.
I have another question. I was thinking about cannabis. I know this is outside of what you do. Maybe I actually, maybe it's not. But I was thinking, I was wondering if kind of cannabis marketing kind of follows the same patterns. And I can only imagine that tobacco companies in the future are looking to blunts or something to, or maybe getting into the cannabis business. And if this is sort of going to be part of a trend toward that.
Yeah, so actually, I do a little bit work. So Ohio has a large Medicaid assessment survey, and me and some colleagues in the College of Public Health help them analyze their data and evaluate their Medicaid assessment survey. So I actually help write the substance use report that's biannual. So we look at density. I kind of squeeze that one in there. So we look at tobacco retailer, alcohol retailer, and cannabis distributors in the state. Ohio is medical license only, and they so far have a very strict cap. So in the past 2 years, we have not seen an increase in cannabis distributors. There is a very small business industry push to think about who's selling tobacco, but it is a concern as we're now seeing tobacco industries buy smaller growers and buy smaller tobacco retailers, that we might see repeats of patterns that we're already observing with tobacco retailers.
Yeah, thank you. Yes, Steve.
Hi, Megan. Great talk. I really appreciate it. So I'm thinking about cigarette smoking in rural settings. So in your early slides, that was one where smoking isn't coming down. I mean, I was on some of those papers with you. You introduced me to this topic. So I just want you to, I'm wondering if you would be willing to think out loud with us. In addition to the dollar stores, they are probably a factor in those disparities. But what other kinds of things do you think's going on such that there's this growing disparity of cigarettes, greater cigarette smoking in rural settings, which of course is the big killer. Not that any tobacco use is safe, but the cigarette smoking is clearly the worst.
Yeah. And I would probably kind of try to get that at all the different levels that I had in my model. So yeah, at the individual level, you know, I discussed a bit of the rural culture, but that definitely does contribute to what we're seeing, you know, especially, you know, the work my colleagues and I have done in Ohio, including there's kind of a rite of passage of a male family member providing a younger male teenager with his first smokeless tobacco or his first cigarette. So it's kind of more of this embedded ingrained culture. And we found that just in survey data, you know, often that willingness question with young people, we get a higher indicator of willingness to try tobacco if it's under a scenario where a male family member is offering it too. So there's definitely some sort of rural culture, social norm going on. Working up though to like a broader policy level, often rural areas are less resourced in terms of who's putting forward different policies, what kind of health departments are able to accomplish in those areas. We saw that in the state with smokeless tobacco laws. So a lot of states, when they were, 10, 15 years ago, pushing smoke-free indoor air laws. Smoke-free indoor air laws often started in urban areas that had more well-funded public health departments. And so we started seeing disparities in what kind of counties, what kind of areas had smoke-free indoor air laws. And it was more urban and less rural. And it was only once we started passing statewide laws that those disparities went away. So I think that's a very similar pattern for a lot of policies for tobacco. Urban areas are just a little more advanced in terms of policy and infrastructure and even treatment availability. And so we kind of see these rural areas often kind of fall behind, both in terms of prevention and treatment.
Great. Hi, this is a great talk. I oversee the tobacco program for Vermont. So this is very important for our work. And I just wanted to mention love how you analyze, right, these different strategies and their effectiveness in this lens. In the small towns in Vermont, so we have 250 some small towns, most of them. And we're finding that most of these strategies are really difficult, right? Because if you have, I live in a town of Virgins, there are 5 or 6 tobacco retailers. But to make any changes to limit that is very controversial, right? Because it's livelihood, it's people and the list goes on. So I wanted to mention 2 things. So one is that I loved your analogy to the statewide, right, role and responsibility for applying an equity lens, but informed, and that we have been looking at in our state, for example, there is every 3 years an opportunity to go through rulemaking process for each of your agencies. And so this year is Department of Liquor and Lottery, which oversees tobacco. And we informed around what Los Angeles did 2 years ago, kind of quietly, in putting a condition on the license to restrict flavored tobacco products. And we so basically brought this up to the rulemaking authorities around, is this a possibility for Vermont, because the other strategies you listed are very difficult to do in some of our rural areas. So that was just one mention. And the second is maybe to consider looking at pricing as a fifth category. When we look at our data from our tobacco retail data, we've done audits of all our tobacco retailers, and there's about 830 some in Vermont. And that pricing, there's higher likelihood of discounting in the more rural towns. And that pricing is so influential in how it's done. It's done electronic coupons, it's done in retail environments, right? You can go into a store and see discounting right in front of you. By $2 off, or even by one pack at the other pack free. This is not allowed for alcohol in Vermont, but it is allowed for tobacco. So we are really pushing for parity among the substances to be treated for pricing where you cannot go below a minimum price for the product, as well as that discounts should not be permitted anywhere in Vermont for tobacco. So just wanted to mention those few things and put in a plug for pricing.
Thank you. Those are all great strategies. I'm glad you all are working on them. And I will mention though, as I'm a big fan of licensing law strategies, sometimes the forward focused approach of licensing and law strategies does help with resistance. So, emphasizing we're not closing any existing businesses. We're not impacting anyone's current livelihood. We're just preventing new places from opening, but I know that could be very hard to push forward.
That was great news from Rhonda, because I encourage the audience to Google discounts paid for by tobacco manufacturers annually. And it's in the billions, and tobacco manufacturers don't waste money. So you were really going after an important one. I think, Rhonda, that's great news.
All right, any other questions? Anything from our remote viewers? No, okay. All right, I guess we will wind up the session and thank our speaker again. Thank you all.